Snyder. With Paul, I founded this group a little over a year ago to bring together technologists and healthcare providers. Let's see if I can get this page down. There we go. So we call ourselves the Healthcare IT SIG. Normally, in a special interest group in SVForum, you're going to find people from a lot of different communities, either developers, sometimes investors, and I think we have that kind of a mix here. Can I see a show of hands? How many from the investment community? One of our speakers and another. How many would you consider themselves developers? And how many would consider themselves hardware specialists? So a good mix. And we want to bring together some of the technology people with people from the healthcare provider side. Tonight's topic is a broad one if you just say remote monitoring in healthcare. You can use words like telehealth, mHealth, mobile health. But I wanted to bring it down to a little more focus. So I said, let's look at this one thing called the medical home. And you can't see the fine print here, but when you see the slides online, the American Academy of Family Physicians and several other medical provider organizations, a number of years ago, came up with the idea of focusing their attention on people who have chronic illness or who have recently been hospitalized, how to reach out to them, work with those patients and sometimes their families to make sure that they either get well, get better, or at least maintain and don't end up back in the hospital. Well, there's been a lot of talk recently about how to go about doing this. And it's really, there's some low-hanging fruit on how to do this. Doctors figure if you can get someone to go to their follow-up appointment with a specialist, that's huge, because by the time they do the statistics on it, half the people who are referred to the specialist don't ever go. They don't ever get the extra care they need. So the continuity of care is a phrase you'll hear. All this kind of stuff that's going on right now is to try and get that low-hanging fruit. But we want to look ahead a little in the future. Once we have electronic medical records implemented for people and coordination of those across different clinics and doctors' offices with health information exchange, and we have doctors receiving email from their patients and able to respond in a secure web portal kind of way, once those things are widely established, there's more that can be done. And in the conversations that are happening right now, remote monitoring just hasn't really been discussed, but a little bit. So tonight, I want to try and invite the speakers we have here tonight. I've asked them to focus on how this is going to help the patient-centered medical home. And in fact, there was a study done a couple of years ago by PricewaterhouseCoopers. Hard to read the fine print, but physicians were asked, what kind of monitoring do you want? And the top 4 things are really simple things. Weight, blood sugar, vital signs like blood pressure and pulse, and the level of exercise and physical activity. Things that we have monitoring devices for. You'll hear more about tonight. There's also regulatory drivers. The High-Tech Act back in 2010, a little hard to read here, but monitoring of patients, particularly that facilitate home health care and the monitoring of patients recuperating at home. So it's in the legislation that this is a good thing to do. And also, it's recognized in the meaningful use guidance for electronic medical records that being able to incorporate data uploaded from home monitoring devices. Well, that's what we're going to talk about a bit tonight. I think that is actually not that easy a thing to do, as you'll hear. There are some obstacles.
Excuse me, what meaningful use stage is that? That's not 2.
No, this is 1. It's from 2010. So the 2 guidance just came out.
So remote monitoring is in 1?
It was mentioned.
Oh,
okay. It's alluded to. Then the Food and Drug Administration has also weighed in that they feel there's some things that they need to evaluate to make sure that things are done safely and effectively. And then you'll hear tonight a little bit about this interoperability issue. This is a bit of a mishmash of a drawing, but if you can imagine that you've got any number of devices on the side here, whether they're scales that can talk to your phone. I forgot to bring in my example of a blood pressure monitor that talks to my iPhone. Whether you're on a Wi-Fi network or Bluetooth, aggregating that information, having a special interface, sometimes a communication center, a call center, where the data is monitored in real time, and then ultimately to the electronic medical record. So these are some of the background ideas I was thinking about, and I've asked our speakers to consider in putting their remarks together. And that includes someone from Frost & Sullivan, Greg Cressy. I've heard him speak before at another forum, and in fact, Frost & Sullivan just recently published an article on a report on telehealth, and I think he'll share some of the findings. Jack Young from Qualcomm Ventures, and Qualcomm has an interesting thing I think he'll be able to talk a little bit about. It's called the 2Net platform, which is a way for getting the information from devices and aggregating it and transmitting it. And then Dr. Chow is from Kaiser, and he heads up a group at their Innovation Center where they're looking at, as he'll tell you, the kinds of technologies that the big Kaiser Foundation health plan can use in the 2 to 5 year horizon. So without further ado, I'd like to invite our speakers to take some seats up here. I don't know if you're more comfortable all being up here, or you want to take it one at a time. And
it might be tough to sit in front of the screen while everybody's watching.
Okay.
One at a time.
One at a time. And would you like me to advance the slides, or do you want to go ahead and...
I can go ahead and do mine. I like to move around anyway. So,
okay.
So, my name is Greg Cressy. I'm Senior Vice President of the Healthcare and Life Sciences Group at Frost & Sullivan. And in that role, I head up our practice across 3 different areas. We have a life sciences group that looks at pharma biotech as well as diagnostics and life science tools that are mostly what we do is around next generation sequencing there. Advanced medical technologies looks at medical devices and medical imaging solutions, and then we have a connected health group that looks at telehealth and healthcare IT. And in each of those we have a subscription service. We do a lot of consulting, about more than half our business is on the consulting side. Yeah. So just quickly, Frost & Sullivan, if you're not familiar with us, we're a global company. We've been around since '61. We have a syndicated business as well as our consulting practice. And in addition to healthcare, we work across a lot of industries. So we have a telecom IT group. We have groups that work in electronics and security as well as in chemicals, materials, foods. Those are the ones that my team works together with the most. But we cover a wide range of technologies across a large number of countries. So when you look at sort of the source of all what we're talking about, I think in the healthcare side, especially as we look at what we're expecting to see as a shift in remote monitoring and a bit of a spike in the curve of what we've seen as the market for remote monitoring, which has gone along pretty slowly in a relatively small market currently. It's really driven by the increasing cost of healthcare, the need, as we know, through healthcare reform and a lot of other activities to try to address that increasing cost, and to address that through management on the chronic disease side. If you look at really any country in the world, whether it's the United States or whether it's in Europe, where chronic diseases are more than 80%, causes are more than 80% of the deaths, or if you look at developing countries, China and India, the 2 largest ones, they're looking at chronic diseases as really the cost driver in the healthcare system. So this is true no matter where we are in the world. And so within those systems, we're trying to figure out what can we do to address this and manage care better. And essentially what we're trying to do is to take some of the dollars that we spend heavily on this end of the spectrum, on the chronically managed or often unmanaged side, and move it to the left here so that we can start to prevent chronic diseases and prevent that instance and prevalence rates that we currently have from accelerating farther and raising the cost even higher. So we're seeing dollar shift, and that's being done through tracking of health conditions, and so that's where remote monitoring often comes in, predicting, intervening, and managing. And these are the shifts then that really define what's going on in a lot of the changes in healthcare and where healthcare IT comes into the solutions in the healthcare world. So part of that is identification and prevention. So part of the identification side is through monitoring devices that will feed information into providers and into analytics models. New models of care delivery to increase collaboration among providers. That's where the patient-centered medical home comes in, as well as, you've probably heard of ACOs, accountable care organizations, which are part of healthcare reform through CMS. But interestingly enough, there are as many ACOs being formed in the private payer market as there are in the CMS world, right, in the public payer side. So this is a trend that is not just related to healthcare reform, but is moving forward across private and public payers. And then where we're not quite yet, but we are looking to move farther down this path, increasing intervention and incentivizing better chronic disease management. So that incentivizing partly comes through a shift in reimbursement, which you probably are aware of, we'll talk about briefly, and part of it then through the ability to intervene more often and probably in a different way than we currently do with patients. For those of you who aren't as familiar with the patient-centered medical home concept, the idea is to try to connect providers in the very fragmented world that we live in. If you're not a Kaiser member, which I am very happily, and you have that connection already through a systematic approach that Kaiser takes, bringing together primary care specialists, the hospital environment, clinics, etc. For others, you're looking at a very fragmented environment, and the U.S. is probably one of the worst countries in the world in terms of healthcare fragmentation, where you have essentially different business entities and different information systems from primary care through hospital, through any other clinics settings you might encounter, pharmacy, as well as then imaging centers, etc. So you don't have a way to really integrate that data very well or get that information collected if you're trying to provide a more holistic solution, manage somebody. As David talked about, many times the primary care physician won't even know if the person went to see the specialist until the person comes back into their office and they said, did you go see the specialist? And the person says yes or no, which may or may not be true, right? So how do we connect those people together? How can we make sure the primary care physician is able to understand they saw the specialist, is able to confirm that they received a refill on their prescription, is able to then start to be the center of connecting the information and the caregivers across a care continuum. And that's really what the patient-centered medical home is all about. It, of course, then involves a lot of healthcare IT solutions, because part of that connection, ideally, we're going to do through electronic means as opposed to phone calls and faxes and the way we do things today in the healthcare world. And part of that is in connecting back into people's homes. So this is where remote monitoring as well comes in. And that's, in I guess, one slide version, this is what the patient-centered medical home is all about. So if we look then from what we do at Frost & Sullivan, tracking markets and understanding how things are changing, we look at in the top left here, a shift in where the dollars are going to be flowing over time. So you have 2007, 12, and 25 here. And this is not necessarily showing a decrease in the absolute number of dollars spent on treatment, but saying in a relative sense to each other, we're going to be spending less on treatment in the future and more on prevention, diagnosis, and monitoring. And so where we spend almost all of our money on acute care today, we're going to be trying to shift again that money back to the left in that diagram, spend more time on preventative care activities, spend more time on monitoring people once they have been identified as having a condition that we need to be aware of at home to try to keep them from getting back in the hospital and impacting the cost with catastrophic events that are quite costly to the system. How are we going to do that? Well, if we're going to intervene or have more touch to people, and we're going to do it at a lower cost, we can't keep using the system that we have today. We need more technology involved in that. So we're expecting to see a lot more telehealth solutions, whether that be video conferencing solutions, whether that be email solutions, whether that be simple phone follow-up, maybe through lower cost healthcare personnel, whether that be through mHealth applications, whether that be through remote monitoring. If we're going to have more preventative activities, if we're going to have more intervention and interaction with patients, then we're going to have to do it through lower cost solutions. So the future of healthcare is not just in-person patient health solutions, but it involves telehealth solutions, again, across this continuum of what we need to do in terms of prevention, in terms of diagnostic, in terms of managing people that have chronic diseases, and monitoring and follow-up. We then go out and size markets, part of what we do in our work. And so we look at, when we recently published a study that David was referring to, we have a whole subscription around telehealth and published studies on each of these different applications. But when we looked and rounded up the whole market, we said, okay, what are the top 20 markets in healthcare or in telehealth? And the first one that we identified is not actually the largest today, but we feel over the next 15 years is going to have the biggest impact in terms of not only market size, but also in terms of moving the needle on changing the healthcare system and impacting health outcomes. And that is what is tied to patient monitoring. Patient monitoring you could tie to a lot of different markets. We have it tied to four or five out of our top 20, just so you know. But home monitoring and health and disease management monitoring, we believe, is where we're going to see the biggest impact in terms of, again, moving the needle on changing health outcomes and impacting the system. And we base that based on our analysis across the dollars in current opportunity, long-term growth and short-term growth, the transformative potential, and what we see as in terms of current, but also future best business models. So this is an important market to be aware of. There's a lot of activity going on. I'm going to leave it to my colleagues to talk about a lot of the different applications and solutions that are out there. And I'm going to focus a little bit more on sort of that big picture and how we see this changing. So many of these characteristics on this side, which we've titled here, what healthcare stakeholders probably won't buy in 2025, is where we are today. But this is what we see as what's wrong with patient monitoring solutions in many ways today. And here's where we believe it's going. Right now we have a lot of single applications, each have their own device. Many times they have their own hub in the home, and that's part of what TUNET is trying to resolve, trying to get patient monitoring companies out of the business of trying to put a piece of hardware that is a hub in the home, right? Have a hub that it can work with every piece of hardware out there. They have their own communication channel, they have separate dashboards and interfaces. And one of the reasons this industry can't scale up, if you look at remote patient monitoring, if you follow healthcare, for the last 20 years people have been saying, this is a market that's going to explode, this is a market that's going to explode, right? The boy cries wolf long enough, people don't believe it anymore. And people have been waiting for this market to grow for years. It hasn't. It's staggered along. It's had decent growth rates, but off a very small base. It's mostly backed by small companies, even though they've been bought by larger ones in many cases. So you have Bosch, who bought Healthier up the road here, or down the road. I live on the other side of it. You have, Honeywell, who bought into Home Ed. So they're still big companies, but these divisions are pretty small entities within those larger companies. They haven't had the ability to scale up. One of the reasons is they're trying to own everything and own that box that's sitting there and try to deploy those boxes, try to get them connected, try to make sure they have a call center so that if they don't get connected and grandma can't make it work, have a nurse call up, make sure that grandma knows how to operate it, et cetera, right? It's a very difficult business to scale. And it's the information flows then are very fragmented, which is the main problem we have in the system. Physicians, in general, these solutions have been sold out to the healthcare provider community, and physicians then are supposed to monitor and take actions to interface with the patient. And so there are physicians who have purchased these solutions or have them deploy with their patients, and they start to receive those data streams. And around certain conditions, that can be valuable and useful. But if you're looking at it from, say, a Kaiser perspective, and you say, now we're going to have 20 different systems tracking 20 different conditions, on old man Caresi, who's 75 years old with 4 different chronic diseases, I don't think so. And they're going to have liability issues if they can't monitor and manage all those information flows that are coming into the system. Lots of single-purpose devices, hubs. I think I mentioned that. Collecting patient data is the goal. That shouldn't be the goal of the solution if you're trying to build one. And they depend on reimbursement, which is why the market has never gone anywhere, because there isn't reimbursement for most of these solutions, and so therefore the solutions don't develop. Now we're expecting that to change now as we shift to ACOs and providers are now being reimbursed based on outcomes. They would start to be more interested theoretically in tracking in the home without having a specific procedure reimbursement tied to that. Okay, what do we want to get to? Well, we want to get to that point where data flows from many devices go to an integrated platform running analytics on a holistic view of patient parameters. Okay, and part of what we'll talk about today is we are taking steps in that direction already. Initial patient interaction is automated, so you have a much more, an easier way to scale it up, and you have an easier way to deploy, right, than we currently have today, which is very labor intensive. Applications are driven over or connect through common consumer devices, right? So the movement is to this or to a tablet as opposed to a interface that somebody has built, apologies to Intel, and trying to place into every home, right? Driving patient behavior is the goal. It's not about data collection, it's what can we do to change patient behavior. And then who are the buyers? Well, in this world, probably providers, payers, employers, and consumers are going to buy. We expect to see a lot wider range of solutions and a lot more stakeholders that are probably going to take interest in purchasing them. Maybe there are for me as an individual. More often, they're probably going to come to the payer-provider community. What are the challenges then that we face? Well, we mentioned the reimbursement challenge. This is what's held the industry back for all these years. I mean, I didn't come from healthcare. I came from the mobile and satellite communications industry into healthcare. And when I got into healthcare, it's like, you know, where's the business model innovation? I mean, there's one business model, you're waiting for the government to say, yeah, we'll pay for it, and then all the other private insurers to follow along. Right? There needs to be business innovation in healthcare. We're starting to see that happen. Remote patient monitoring is not one of the places that's been very active, and while we've been waiting for reimbursement, that growth curve has struggled along at that very low growth rate. All right? The change in reimbursement that involves ACOs, accountable care organizations, payment for outcomes, starts to change that somewhat and get people more interested in understanding more about what's going on with that patient outside the hospital. Scalability, I mentioned this. This is one of the key factors that, again, has held back the remote patient monitoring market. It has been very hard for companies in this market to scale up solutions. Very labor intensive, trying to get those boxes into the home. Much easier to scale if you're using a common consumer device. Could be a tablet, could be the home TV, it could be on a mobile device, it could be in a variety of settings using, for example, 2Net's solution, which could create a different piece of the puzzle or solve a different piece of the puzzle. Fragmentation of information. The fact that, you know, when you look at what's going on in this space, whether it's you're talking about, as you define it, might be mHealth or remote monitoring, there are lots of things going on. There's lots of there's ability to generate a huge amount of data points. But those individual data streams in and of themselves don't necessarily create value, right? This fragmentation is a huge issue. It's part of the problem across healthcare, and almost any area of healthcare you look at today, whether it's information, whether it's the provider side, or whether it's the data end, right? Fragmentation is not the solution. We need integration. So again, we look at Qualcomm Life and what they've done with 2Net. Part of that is to start to integrate the data, right? And the data flow and the communication side. We also need the integration of the data on the back end. I think that's probably what Jens is going to talk about a little bit as well. Okay, we look at markets as developing, and you know, they develop along a path of, okay, first you have technology that you can apply and develop applications, but eventually you got to get to a solution. And a solution is often complex and doesn't just involve technology, it involves maybe different levels of intervention. If you say, okay, here's an application I can put on my phone, it's going to remind me to take my meds, right? So it sends me a text message that says, hey, you forgot, you know, it's time to take your meds. Well, fact is, medication adherence, 10% of it is related to forgetting. So sending me a text message is going to solve 10% of the problem, but not 90% of the problem, right? And that problem is different for me than it is for you, than it is for you, than it is for you, right? There's a lot of factors that go into why people aren't adherent. Some of it's side effects, some of it's that it doesn't fit within their daily routines. Some of it is they don't think it makes them better because they really don't understand the health condition of the medication. And actually, because of the side effects, taking the medication makes them feel worse than not taking the medication, right? So, you know, sometimes it's money, sometimes it's their social support system, sometimes it's a lack of understanding of their condition. There are all these factors involved, but we're going to say, okay, we send them a text message, that's going to solve the problem. That's not going to solve the problem. That could be a level 1, send them a text message, cheapest, easiest thing to do. If I don't, make me push a button that says I took my med. If I don't respond, then shoot me an email. If I don't respond to that, get me on the phone. Start to engage me about, why, it looks like you didn't take your medication. Is there anything going on? Try to find out that I actually hate the side effects and I'm not going to take this medication anymore. Sorry, right? The simplest solution that's often been said to our healthcare problems is to get people to take the meds they're already prescribed, right? If you look at medication adherence rates, it's 50% after 6 months for almost anything, even for chronic, or even for diseases that can kill you, right? So just getting people to take their medications, but how do we look at that as, instead of a technology, sending a text message, as a solution that really gets at some of the source and has different levels of intervention to solve that problem, right? So we have a lot of activity out here on technology, and nowadays we've got a huge amount of activity here on apps. We have very little in terms of solutions, and that's where we need to get to. And this is a little bit of a related picture saying, look, we're collecting a huge amount of data points out here from a lot of different sources, but how are we going to create that integration in communication flows, but also in data? And then, more importantly, and this is really where we need to get to, how can we create analytics around that information so that we can now start to give ourselves cues to intervene, start to interact with patients, and really start to change behavior, right? So when we look at remote monitoring, we've got a lot of the basics figured out. We have a huge amount of activity on a lot of the data, a lot of the creation of applications. What we got to get to is that more holistic view is where we're still lacking, and that's where we need to see this market progress if it's going to reach what we expect to be the impact that it will make, that cause it to be rated, or at least the disease management side of it be related to that #1 ranking that Frost and Sullivan believes is relevant to disease management and remote monitoring. So with that, I'll turn it over to our next speaker, Jack.
Thanks, David. Thanks, Greg. Hi, everybody. I'm Jack Young from Qualcomm Ventures. Before I start, I also want to introduce my colleague, Lucian, who's a medical doctor, just joined Qualcomm Ventures not too long ago. So lots of medical questions directed to him. So one thing I want to talk about is obviously coming from Qualcomm, no surprising to talk about mobile, but I have a quiz here. Actually, how many people know the answer? In market cap wise, which company is bigger, Qualcomm or Intel? How many people will say Intel? How many people say Intel? We got one person. All right. Yeah, so we're happy to announce since last Friday we have exceeded market cap in Intel. So that's all propelled with the population of growth of mobile devices. It's hard to believe the penetration of mobile coverage in this world has exceeded clean water and electricity. Think about it for fun, right? People would having trouble to get electricity sometime in New York. Just the cell phone still works. So what does that mean to healthcare? What does the device mean to you? So one of the things is the device is always used with you, right? Someone may be carrying multiple devices with you. But in terms of where we see patient monitoring, but I think it's actually profound and transformative. So why do I think this way? Because if you look at the device yourself, the one you're carrying in your pocket, it comes with a battery. So why is that important? I'll explain to you. It comes with computing powers. You talk about quad cores and so on and so forth. It comes with a network, high-speed network, sometimes cloud computing, with HD display and internet. So internet comes with your social networks. And it's always in your pocket. So what does that do with the medical devices? So here's an example, and unfortunately we also have a representative, John, from the company called AliveCore. This is one of the Qualcomm Live Fund investment company. So what this device do is basically it turns into iPhone into an ECG device, a single lead ECG device in your pocket. So assuming that you have certain heart conditions, and some probably unfortunately know you have atrial fibrillation symptom where you have an irregular heartbeat. It's really hard to capture that in a traditional way. When you go and see your doctor, they say, hey, well, because it's transient, it's hard to catch, so we're gonna prescribe you a device. Sometimes some of them may knowing as a Holter monitor that you get wear this thing on your waits for 2 days, and then it'll take to the physician, and they'll try to diagnose that symptoms for you. But it's really difficult to do because it happens, it may not happen. So with live core devices, that basically changed that equation. So what this device does is that it's an iPhone case that fits nicely to an iPhone 4 in this case, and many other smartphones. So with that, because you have that device with you all the time, and so the mobile phone I mentioned about the attributes earlier, right? The power of computing, the display, etc., etc. So all of a sudden, instead of making this ECG device, which otherwise would cost you $300–400 to make that, with the batteries, processing powers, and let alone it doesn't even come with internet that you have to pay monthly. All of a sudden, this thing is just piggyback to a device you already have, the $500 horsepower device you have in your pocket. All we have to do is make a very simple, non-intrusive device. So all of a sudden, that power is in everybody's pocket. So that's what happens with this mobile devices. This is just one of the examples. And look at some of the examples. It's a profound experiment we did just by, actually this is one of the experiments we did with USC, a conference like this, most of the professionals joined. So we did a sort of a clinical trial. So all it does is basically hand out about 50 cases to participants. The only requirement is whether you have an iPhone or iPhone 4. So the participant was asked to measure, your friend, yourself, and just to try to use it, and see how often can you use it. And what happened is in that 8 weeks or 50-some patients, we found a number of incidents leading to hospitalization, to ablations, whatnot. So just show you that even as simple as this is the experiment, we can catch a lot. And talking about patient monitoring, anything that you can detect early saves life, right? So some of you probably follow mobile health know Dr. Eric Topo. This is right off to science fiction that he was on the plane, and the captain says any physicians on board, plastic surgeons show their hands with. Dr. Eric Topo is a cardiologist. Took the device in the back of the plane, put this thing on the chest, and tell the captain this passenger is having a heart attack. The plane actually went down. So I'm not saying went down. To safety. So just to show you one of the examples. So there are many examples in patient monitoring. I think my colleague Grant gives lots of very good examples and talked lots about the existing problems. So I wanted to, in the interest of time, I want to give you a quick example of what can be used in what's the use case for patient monitoring, right? So lots of people say, well, you want to monitor this patient, there's the ACLs, etc. But I think one of the biggest area of interest is actually monitoring the senior citizens. So as you know, there's 10,000 senior people are turned 65 years and older, and today there's about 12% of the population, or some 36 million people 65 and older. And the aging population, the wave of aging population is coming. So next 2 decades, that percentage is going to go nearly double to reach about 77 million people. And the older people, unfortunately, are the ones who consume the health resources. Right? We talk about the close to 20% of GDP expenditure on healthcare. There's 13% of the senior population today consumes 40% of the total. And if I mentioned earlier, as this wave continues, that situation only getting worse. Why is that? Because the senior people 80% of senior people come with one chronic condition or more. So these are all the expenditures. So I think monitoring, you really have to pick one of the area that if anybody needs more is to monitor the senior people at home. And the other thing is, as the senior population increases, especially in the developing nations, that we find another thing is the available healthcare workers, if not reduces, at least plateaus, right? So as a result, as the senior population grows, and the available health workers very relatively stable. So as a result, there's going to be a huge demand and supply gap. So some of you probably know you have elderly mothers and grandmothers that living at home. There's this thing called home care services. Some have probably heard about. You can have a home care service worker to your home to work 3 to 6 hours to helping you your daily living to pay about rate of $20, and my prediction that's going to go by the time you retire, it's going to be $80 to $100 because this gap of supply and demand, because the population, what we can do is lots of things you can do is to using technology to bridge that gap. So some of the things can be remotely monitored and administered instead of having a person at home. So a huge driver there. The other thing is, I think we talked about the ACL, that whereby now that all of a sudden hospital not only just providing a fee-for-service when you get in the hospital, but when you discharge from the hospital, at least for the first 30 days, they have to make sure that you are well enough not coming back, so occupy that bed and they don't get paid for doing that. So I think this is one of the very clear market. If anybody developing products and services, I think there's a clear demand and driver to drive that. So I see a lot of opportunity to push in that application in that area. So in terms of senior care, I think there are lots of solutions out there. So it depends on the progression of the senior aging, right? So when you're 65, you're happily retired, you have lots of mobility, so people do work around. So you're probably going to starting with some kind of light patient monitoring solution. I'll show a couple examples of these so-called personal PERS services, whereby personal emergency responsive services. You wear this little pendant watch, so in the event of fall, it will automatically detect and call for help. Or there is other kind of a tablet that you can use, give you all the medication reminders and all kinds of medical devices at home. But as you progresses, getting older, then your choice of mobility limited. So your requirement for monitoring may be intense. So in certain cases, we have seen companies that are providing these wired at home with sensors. So the idea is that you can be passively monitored. So that kind of machine monitoring can happen 24 hours. So instead of you moving to a care facility, which is going to cost you a lot more and limit your mobility and sacrifice your dignity, with this kind of remote activity daily monitoring with a vital monitoring, prevent you away to aging in place longer and hopefully at a more affordable cost. So again, these are the examples that cover the continuing care of the senior. So in the broader base, that you probably see lots of these monitoring devices not only applicable to the senior population, which I think is a huge demand for that, but the other thing is for the general population, whether in the wellness sphere, that you have these wireless connected devices from a scale to a pedometer to heart strap to anything. There's probably more and more of these quantified self companies in the Bay Area. Every day there's new devices to be launched that help you to track your activities and count your calories. And from a disease management perspective, it's just again from head to toe, you have your sleep monitoring. These are all consumer grade devices. You have SpO2s and blood glucose, and I mentioned ECG devices. So all those devices that Greg mentioned earlier. So what are you going to do with this torrents of individual data, right, coming rushed to the system? The doctors won't be able to look at all the devices, and especially they're from different vendors. So what is Qualcomm, we are here to jump in for help is that realize that more and more of these devices are coming to the market, and just about everybody want to have a way to monitor these devices, but it's awfully difficult to connect these devices from the patient to the healthcare providers. Lots of devices are proprietary protocols, they have their proprietary APIs, or with the different variants of these interconnectivity capabilities. So what Qualcomm does is that we come up with this thing called 2net platform. So there's two parts of the 2net. One is the home gateway device, and the other is cloud services. The home gateway device is basically, it's like a Wi-Fi hub, except coming with the cellular. So when you plug in that device, think about it as basically, it's a headless Android device. You plug into the wall, automatically finds the cellular networks, make that connectivity to the cloud, and it's secure and HIPAA compliant. On the downstream side, has a number of local area networks protocols, whether it's Wi-Fi or ANT or Bluetooth. And the beauty of that is find automatically the devices, automatically discover those devices and pair that. Now think about that's very important. Think about if you have a grandmother, right, gets discharged in the hospital, you're not going to ask the grandmother, do you have a Wi-Fi at home, do you know how to pair Bluetooth? The beauty is you should be able to hand it out a device to say, take it home, plug into the wall, at certain frequency you should do A, B, C, D, right? So this device basically solves that problem. Ideally, that we're working with over hundreds of these ecosystem providers, from scale to a concomitant to all kinds of things that automatically provide that experience that patient has the least involvement, and all this data are secured, send it to the cloud. Again, at that point, everything's secure in the cloud, and as far as the healthcare provider is concerned, they're getting this data feed, the commodity data feeds to the physicians so they can build, whether it's analytics or displays, whatever thing they want to do, that they can provide upstream. So what Qualcomm does is providing that transport mechanism. Now, the gateway itself is not limited to the hub. This is what we think it's the first wave, because lots of people have these devices and they find a way to connect. But the future ways, you can think about using a mobile phone as a hub or other ways to connect it even through some embedded devices. But the goal is that for healthcare providers, they don't have to deal with a single strand, single vendor solution. Here, there's an opportunity to address all this data feeds and data stream. And the more important thing is, once you have these multitude of data available, then you can provide a comprehensive view of that patient, right? If blood pressure itself may not mean much, but it aggregated with their glucose or weight tells you a lot more. So there's an opportunity for other industry players to partner with us to providing informatics on top of that, eventually provide that the first defense of patient monitoring. Is Qualcomm concerned that we have not only built that platform, but we've been actively building a lot of the industry ecosystems, whether from a trade organization. Some of you know we are very much participating in some of the very well-known organizations, TEDMED, ATAs, a number of research organizations were sponsored by USC, a very prominent cardiologist over there. In the Bay Area, we're involved with the Rock Health Incubator. Very active. Also on the government affairs side, a number of things that we have done a lot. So if you were to be looking at, a mobile health patient monitoring, you've probably seen a lot of Qualcomm. So back to the investment side, which is basically my job in Qualcomm, is that we actually, with a good understanding from the information and technology side, obviously there's lots of learnings here. So what we have been doing is collaborating with biotech and medtech investors. So together we are making new waves of these investment into connected devices. So lots of these devices are being used for patient monitoring. Sotera Wireless, for example, providing a comprehensive patient ambulatory monitoring system, initially deployed for hospital, but eventually be able to deploy at home. At least the vision is to provide that continuing monitoring from hospital to the patient home. Many examples here. Obviously the investment is being accelerating. Unfortunately, I didn't get a chance to update that, but the point here is that in wireless health, last year was kind of the first year really break into the scene. There's about 15 companies, some of the companies I mentioned earlier, about $240 million invested in this. And this year, mid-year, we already exceeded actually $300 million, about 40 deals. And this year, I predict we'll exceed $600 to $700 million into wireless health alone. That's a big portion of all the digital health deals we've seen. And many companies are here in Silicon Valley focused on areas I touched on earlier, from wellness to fitness. Lots of companies, Fitbit, for example, a local company here, to chronic disease management solution providers, and then care in place, whether it's a transitional or aging in place. And lastly, there's a number of disruptive technology that people are going there. And we have been working with many other venture investors, both the corporate, the GEs, the Intels, as well as the Sand Hill Road. The familiar names here, Khosla, KPC. So Lucian and myself, we are co-managers of this fund within Qualcomm Ventures. Qualcomm Ventures is a $500 million fund starting in year 2000. And last year we have established a new fund, which is called Qualcomm Life Fund. The whole goal is to accelerate into the wireless health. a large portion is the monitoring devices I mentioned. So we have a 6-company and growing portfolio of some of those, I would say, more or less household names in the wireless health, right? So we're happy we have this elite collection of companies, and you should see announcement from us in the next 2 months with additional investments made out of this fund. So lastly, I want to conclude that not only we invest, the business invest in ecosystem, but Qualcomm also create a challenge together with XPRIZE Foundation to build this tricorder devices for remote patient monitoring and diagnosis. Some of you know it's a $10 million endorsement from Qualcomm. So this is ongoing right now. Very, very exciting. So, yeah, so that's my presentation. Thank you.
I'm a physician with Kaiser Permanente. I'm so glad that Greg referred to Kaiser Permanente. I'm going to give you a very quick overview of Kaiser Permanente in case you're new to it. It is the largest private integrated healthcare system in the U.S., so it has characteristics that make it very different than other kinds of healthcare systems. We have almost 9 million members, 15,000 physicians, also known as CEOs. 167,000 employees, 36 medical centers, a whole bunch of big numbers. About a third of Kaiser is Northern Cal, about a third of Kaiser is Southern Cal, and a third is the rest of the country. And you notice that in our different regions, we really have very different kinds of markets and structures. For instance, in Colorado, we don't have hospitals, we just have clinics, so we use other people's hospitals. In Northern Cal, it's all, wherever we go, you see Kaiser. So it's a very different setup, and therefore the demand for telehealth varies. So it's very important to keep in mind. I also want to mention that we are very early in the EHR, electronic health records. We installed the Epic system in 2003 across the entire company, and it took us about 7 years to get it all implemented, hospital by hospital. We have a patient health record portal, which is tied to the Epic system. And we have 9 million patients. We have about half of our members are actually using it actively, an online portal, which is pretty amazing. So I was glad when David asked me to talk a little bit about remote care. And I'd like to introduce 4 models that we've seen. Actually, there used to be 3 models, and then the 4th one just popped up this year. First, we have live video, in which we are very interested in Northern Cal and Southern Cal, and some of the other regions. It's a synchronous communication between the patient and the physician, or between the physician and the specialist, or different combinations. And you can imagine that it saves a lot of travel time. The reason we really like this model is because it is something that's very familiar to the physician. It's very much like an in-person visit. The problem with it is that everybody's got to be there at the same time. So if a physician is seeing a patient remotely, you don't necessarily avoid the issue of scheduling, as well as you may actually take as long as a regular visit. So it actually doesn't make the physician more efficient. But it's potentially very popular, and patients love it. So it saves travel time, but like I said, and it saves a member inconvenience, but it doesn't really save productivity or efficiency. The next model does. This is a store and forward model. And this is where you take a picture or a video, and then you just send it to the physician, and the physician sends back the diagnosis and the recommendations. This does save travel time. It's more efficient. We have a model in Northern Cal based on teledermatology, where you walk into a clinic, and we piloted this last 2-3 years. You walk into the clinic, and then let's say you have a rash that your physician doesn't know what it is. So you get the option that if you want to hang around for about 15 and 20 minutes, you'll send a couple of photos to a dermatologist who's on call, and you'll get the answer back, and you'll get the treatment back. And we've had a lot of uptake on that, and it's been very, very successful. Yes?
So, I'll give you a recent, my experience that happened. So my daughter has extreme eczema. And I suggested to the doctor that I will give you pictures and you take a look at it. And he says, oh, forget it, you just schedule a visit and come back after 10 days.
Yeah. I mean, it's you know, having people come into the clinic a lot, it's time, people very much they cherish time, as do the physicians. And it's so, dermatology being a very visual specialty, this is perfect for it. There are other specialties that are also very good for it. The thing about this that we found is really interesting is that a dermatologist will see a patient, it takes 20 minutes. But if you use this, it takes 7 minutes. And they can handle about 60 to 70% of the time the entire transaction within the online model, which means that they can be almost three times more productive, which is very interesting. So that's why it's very, very interesting. Although I think many of our regions are more interested in the video. The next one is the remote monitoring paradigm. I think Greg was correct and Jack was right about this. This is coming on, but it's very slow. And for many of the reasons they mentioned. But there's so much potential that intuitively you feel like it should be in place. And the real advantage of this is that you can detect things a lot sooner. So they can intervene sooner. You can prevent the rehospitalizations, the morbidity that costs a lot of money. And it's also better for the patient. But it requires the patient to be engaged and cooperative and fairly with it. So it's interesting, you know, there are people that are doing all kinds of, I'm in an innovation group, so I see like literally hundreds of startups. And there are startups starting to address that issue too, both in terms of social networking and also using home health aides who are paid $10 to $20 an hour, using a very simple interface to ask the patient some questions so that they are your proxy. So they see the patient every day, you know, and so they ask the patient, and they hit the buttons, notify the physician, then they intervene. So it's kind of interesting. The last category is one that just popped up this year. We're seeing some startups doing guided self-service. And potentially, I think this is exciting because this is right in line with sort of the patient empowerment principle, but also it's very scalable for a healthcare system. If you can involve the patient and provide services to the patient that support this, we can do things like guidance, health education, we've done for a long time, preventive care, social networks, self-management, but it also requires engagement.
So that's boutique type paradigm?
Yeah, there are actually startups doing just that.
Okay, yeah.
How many of you have seen a Gardner Hype Cycle? Okay, some of you. Okay. It's a curve that technologies go through when they first come out. The vertical axis is expectations or hype, and then you have time on horizontal. And Gardner found a curve that happens for most all technologies, which is when it first comes up, there's a technology trigger, so the hype goes way up. And then you reach what they call the peak of inflated expectations, which is right up there. The iPhone 5 is probably there right now, I don't know. So, and then right after the peak, it falls precipitously into the trough of disillusionment. And then it goes up the slope of enlightenment and then to the plateau of productivity. And at that time, you only have 20 to 30% mainstream penetration. So this is very early. And my group looks at the first two phases. But where's telehealth today? Take a guess.
To the left.
Telehealth is in the trough of disillusionment, which is a good place to be. Because telehealth has been around for 20 to 30 years, right? The technology is old, most of it. So now people are getting to know what telehealth is good for and what it isn't good for. That's where you get the trough. So it's only going to go up from there. So people wonder, why hasn't there been uptake? It just makes a lot of sense that people do telehealth, telemedicine, telemonitoring. But there are a lot of challenges, and I'll talk about that a little bit later. So let's talk about some technologies that we have seen, some interesting things. Jack mentioned and Greg mentioned the hubs and sensors. We still see a lot of this. And like I said, many times it's proprietary. They'll actually say, oh, we send a message in HL7, which is a standard messaging format in medicine. But HL7 is so flexible, you really have to look at traffic, at the data to see what it's sending. And we actually have done technical proof of concepts. We actually looked at the data stream. And it's a crapshoot, you know, basically. So you have a lot of proprietary hubs. And actually, you have it in different form factors. You notice that number one is the Honeywell hub. That's a sort of alarm clock looking type of thing. And then number two is the Intel Health guy that Jack referred to, or Greg referred to. It's like a PC with a webcam, sort of, touch screen, that kind of stuff. Interesting thing about that unit is that Intel decided to put a little slider over the camera because they found through the ethnographic research that people were worried that the camera was watching them even when you turn it off. So, and that's actually true, that's happening today. So they were very wise to put a little slider. And then you have Health Buddy, which is now part of Bosch. Tunstall is one of the first hubs that had a GSM cell chip in it. So that, and that's a trend that we're seeing in weight scales and devices, that they come with these cell chips so that they don't go through the internet anymore. They don't require the elderly person to find a cable connection and that kind of stuff, so, which is very nice. I want to mention some of the new sensors. That's mobile sound done in the lower right. That's an ultrasound probe that's hooked up to an iPhone. So it can potentially take the place of a stethoscope. So you can imagine using this very handy device, plug it into your phone, send a signal through the phone. I mean, in the old days, you'd have an ultrasound device that's this big. So it's really disruptive.
Excuse me, can I ask you a question? You mentioned that some of these devices are actually sending HL7. Is anybody receiving it and ingesting it like into an EHR?
That's another issue.
Because I've been doing a lot of research, and I'll talk about this later. But there's the actor of being the patient on patient-reported data is an issue.
Right.
But sorry.
HL7, there's HL7, there's HL7. So all the device makers will say we send HL7. But the issue is when you translate it through all the different things that has to go through to get to the EHR, and then you find the EHR is not even set up to accept that data. I mean, we did we really looked in detail at that. Our system, Epic.
Oh, no way.
Any other system, no way.
Yeah.
And that's just one of the barriers that we can probably talk a little bit more later, but the issue of having all the pieces compatible enough and understanding enough to accept the data and make it useful and actionable doesn't happen today yet. Number one is a very interesting sensor from Kai Medical in Hawaii. It's a vital sign sensor that you can sense at a distance without touching somebody, by Doppler radar. That came from the military. And so you can imagine that device in your house or in your car, sensing your vital signs without you having to do anything. Very cool. They mentioned LiveCore, that's the device in the middle, the iPhone case with the two electrodes that you can stick in yourself and send EKG. Number 3 is Valencell, which I saw 2 years ago. It's an earbud that can measure your vital signs, but it's interesting, the company told us at the time that it can also measure blood pressure, which is very interesting. You can actually listen to music on it, but it's measuring your blood pressure. It's invisible, that is, it's part of your environment, so very cool. Number 4 is a touchless vital sign sensing in a mattress pad under the mattress. So it's sensing your heart rate, your activity, and in fact we're looking at several of these vendors because a lot of the Medicare requirements now, if you don't turn a patient over every couple of hours and they get a bed sore, Medicare's not going to pay for it anymore. So these kind of things, activity sensors, whether the patient's turn or they're trying to get out of bed after surgery, things like that. Number 5 is by Nissan. It's a drowsiness sensor in the car. You can tell when your eyes are closing, I guess. So nowadays with a Google car, they'll just sort of drive you to the nearest hospital, maybe the nearest smart house. And then this cute little baby in number 5 is wearing a fabric sensor suit for the sudden infant death for the babies. Normally today they go home with an alarm, and if you have a child who has sudden infant death tendency, like a premature baby, you hook up these wired leads to it, you're going to be up maybe 3 or 4 times a night for 6 months. So when I, as a pediatrician, see those parents, they've got these big black bags under their eyes because the alarm goes off all the time. This sensor suit is a lot more reliable, so hopefully it'll be much more useful. And they're building those sensors into your clothes, so you can imagine in the future, not too far future, we might have sensors that we don't think of as censored. It was mentioned that the personal emergency response market is a big one, is actually growing. It's a market where the adult children will actually pay for these devices. as opposed to the healthcare system. It's kind of like a parallel to the medical system. We've investigated a couple of projects to try to get our members to have really, really good deals on vendors that we have vetted. And in fact, in the Northwest right now, we're running a PERS pilot for our Northwest members, and it's very successful so far. I think it's actually a pendant that you can press a button if you have emergency. And then the guy down the right lower side is that's actually measuring the muscle contraction, how well it's doing. Medication adherence is one of the grand challenges of medicine. I think Greg mentioned 50%. I've seen studies showing 80%. Not taking medications the way you thought they would take it. There's reminders, there's pill dispensers, all kinds of interesting things. I just numbered the last three. Number 2 is Proteus, which is a pill with a chip in it. Electronic chip. It's biodigestible. So every time you take it, it dissolves and sends out an electrical signal to a sensor in your arm, and then it tells your provider you actually took that pill. Every pill has it. Magnetrace is a necklace that senses pills that have magnets in them, so you would take the pill, and it goes through the sensors. It's got 3 sensors. This is a science project from Georgia Tech, I think. But the one at the bottom, number 3, is the most interesting, I think. Is Exhale Therapeutics, now called Exhale. And Exhale Therapeutics, what they do is they take the pill and they coat it with a biomarker. So when you take the pill, it dissolves, the marker comes off, and it comes out in your breath. So it's like a breathalyzer. I think that's a lot more practical. And so, yeah, very interesting. Mobile health apps, of course. Guys in the back of the room, can you see the eye chart? I don't know why they put eye chart on a mobile phone. It's very interesting.
Well, the new displays, they're good enough.
That's what they call retina scan, right?
Retina display.
We have mobile apps for KP, of course. We just announced this year the electronic health record is now available. Actually, we came up with Android first and then iOS. And it's essentially you can do secure messaging with your physician, you can do refills, you can check your labs. Actually, checking your labs is the number 1 most used function. And the least used function is actually booking appointments with your physician, which is interesting. So checking labs and then sort of the refills and the medication and the secure messaging sort of take 2 and 3. It's a different interface. When you think about mobile apps, they're not like PCs. You have them and you usually use them for a single function. So we're learning to design these apps not like we did the old PC interface. And people don't want to use it like that. They're not browsing on their phone. They actually use it for a certain purpose. It's a lot more intimate and we can actually track people. I'd like to talk a little bit about what's happening with regulation. Last 2011 was very significant. It allowed the CMS folks actually made some decisions that made it easier to do teleconsultation by recognizing that you can do privileging remotely. They issued some draft guidance on mobile apps. There was a big concern because app developers were scared that the FDA would jump in, and suppress apps. And what the FDA tried to do, balancing safety, safety with innovation, is they said basically you pass data through, you show data, you don't touch data, that's class 1. So you just have to prove quality. You don't have to go through the rigmarole of class 2 and class 3, which is higher risk. Also, in California, the California Telehealth Advancement Act in 2011 allows better, easier credentialing of telehealth providers. And it's interesting, the National Defense Authorization Act, which is a federal act, said that it doesn't matter where anybody who's eligible is and where the provider is. You're all the same system. A provider in Iowa can treat, if they're an expert, treat a covered member in California. You can't do that privately. Okay? You can only do it in this system. But it's pointing the way. Because how you use technology, Kaiser would love to have a National Center of Excellence for neurology. We can't. Because you have to be licensed in every state that you go treat patients in, which is, this debate about a national medical license has been going on for a long time. And technology has just sort of pointed that out really very, very much. Today, the telemedicine drivers are improved technology. I should update the slide. There are now 14 states that require reimbursement for telemedicine. And malpractice insurance is now available. People are more comfortable. One of the big issues has been the literature. When you go to a physician with new technology, one of the first questions they'll always ask, at least at Kaiser, is what is the evidence? And you ask the question, you get a blank, it's like I just did, a blank stare back from the vendor, because technology is moving so fast that you can't have any evidence. You basically, and so what's the right way to think about it? One of the ways is that you realize these technologies are mostly communication technologies, they're not really medical technologies, but they're in a medical context. So one of these days, when video conferencing is on Comcast cable, and I can order it, it's like a telephone. Then it's not a medical device anymore. So I'm looking forward to that day, actually. So it's interesting. It's just the way we think about medicine, it's sort of evolving. There are 4 models on the market that we're seeing. One is the acute care model, like American Well is part of that, Teladoc, those kind of companies where they match a physician with a patient who wants to get seen at 3 in the morning. You see them on video, like on Skype. The problem with that model, because of the fragmented care, is that they can only treat you for like sore throats and maybe urinary infections or something like that. Very, very simple things. Whereas if you could do that at Kaiser, for instance, they would have access to your entire record to treat a diabetic. That's a whole other level of treatment. So acute care is something that's a lot of players are trying to get into that. Follow-up care, Greg mentioned the follow-up care is really poor, and it's true. Worksite care, we're seeing a lot of interest from employers. There's a huge, the part of their expenditure in healthcare is just growing just uncontrollably. And then we're actually working with some employers about kiosks, e-visits, those kind of things. And then worksite wellness. And wellness is interesting. There are startups like Kias, which is Adam Bosworth's startup. They bring a contest, a gaming model into employee site, and where they assign people to teams. And then you get like $200 or $300 at the end of the year if you reach your goals, and if you lose a certain amount of pounds for the whole team. The interesting thing about Kias is once they put you on the team, you can't leave the team. So you can't game the system. So what happens? Let's say somebody's not pulling the weight. What does the rest of the team do? They go down on this guy. You better go and walk, today. So it's an interesting social networking, social pressure. At Kaiser, we've had over 100 pilots in the last 2 decades. And it's interesting, our experience has not been as positive as the literature would suggest, because we're very aggressive with population management. So it depends on the control group that you're looking at. If you go to literature and you compare what people are doing with telehealth and telemedicine, their control group is often like nothing. So they're going to do much better. But the problem is, how do you compare it with what you have and what you're actually doing? And also the other issue is that a lot of these studies are small and they're not really comparable, and they don't look, maybe people are starting to think they don't look at the right things. They always look at things like length of stay or morbidity or readmissions, things like that. There's some evidence that maybe those are not the right things. Maybe we should look at efficiency and productivity of the healthcare system. And the other thing is people tend to put patients into buckets and put them into these programs. And now there's evidence that maybe only subpopulations really should be using monitoring. So it's very interesting. I think this picture is getting better. People are doing much better research, and we're getting better answers. Okay, this is kp.org, which is our mobile and website. And like I said, we have 64% membership enrolled. In 1 quarter, we've been seeing about 30 million visits, or about 5 million visits to the mobile site. We just released it now. Lots of usage, which goes to prove, people talk about websites and medical websites about how they don't get a lot of usage. It depends if you put something in there that people can use, to be honest. Why should they spend time on a website if they can't get anything done on it? And I think that's really important. That's why our website is tied into a medical record. You can actually see your labs. You can actually make an appointment, things like that. If you can put that into the marketplace, people will do it. But not if it's just for education or something like that. But here are some of the challenges. This is my last slide. Of course, you don't touch the patient. Not yet. People are developing haptic devices that can touch the patient. It's not the same thing. There's a lack of reimbursement. I think that's probably one of the biggest issues. Some enlightened payers are starting to pay for it. We've seen some Blue Cross Blue Shield efforts at Cigna and so on. There's a debate about the literature, like I mentioned. There's lack of agreement on the best practice. I think, physicians they've been trained a certain way to treat patients. And when you ask a physician to go, okay, treat your patients using video, they're very, most of them are going to be very uncomfortable doing that because they're at risk, the patient's at risk, and there's no evidence. And so it's all great if it goes well, but if it doesn't go well, the patient will drag you to court and say, how come you didn't see me in clinic? That's why you didn't notice my rash, all that kind of stuff. So it's a huge issue. The business model is not really there yet. We try to build some business models based on telemonitoring and stuff, and it's challenging because there's a lot of issues. What is the true cost of telemonitoring? What is the sunk cost? What is the return, the break-even point? All this kind of stuff. It's very, very speculative. Disagreement on metrics. Difficulty in integrating data with EHRs like ours. A huge issue. I can talk with you offline. It's a big issue. HIPAA concerns, regulatory hurdles, unclear reliability, interstate licensing, those kind of issues all been around for a long time. And as usual, all these things sort of lag behind the technology. But the great thing about today, the reason why it's good to get into this area is because we have no choice. In 2020, the estimate is we're going to be behind 125,000 physicians. About half specialists, half primary care. Being behind that much means that if you want to go see a doctor, you may not be able to see a doctor. That's scary. So that means that we have to do something different. And so the traditional, as Clay Christensen put in his book, Innovative Prescription, the traditional pyramid where the doctor sits on top as a wizard, you just don't have that guy there anymore, that gal there anymore. You have to use rules, like I said, use rules to push the action down, even down to the patient, assuming the patient can take a responsibility. And that kind of model, you wonder, is the American public ready for it? That's the question, right? If we're not ready for it, we're never going to see that. We're all going to keep paying for it, for stuff. But eventually, like I said, the macro trends are that we will have to do something different. So I'm very optimistic that we're at that point. And so,
show the last slide.
Oh, that's okay. Last slide.
Love that.
The world lessons we know now.
Thank you.
Sure.
Well, I'd like to take the moderator's privilege to maybe ask the first question. As I was getting prepared to come over tonight, I was really thinking about this a lot. And with the devices that we're talking about, we talked about people using it in their own homes. And one of the obstacles is, does the person understand it and can they engage with it? But another one comes to mind, and that is, this is a device that's now out in the wild, if you will. And my question, like any of you who want to address it, is what about device maintenance and troubleshooting? For example, making sure that the device is calibrated, or if it's not behaving as expected, doing repair on it. Is it possible to recalibrate remotely, or does that mean a device has to be brought into the clinic or brought into the manufacturer? What kinds of thinking have our speakers seen around that topic? Because if we're going to rely on these things to help the system to not need as many primary care physicians or to prevent people going back to the hospital, they've got to be reliable. What are your thoughts on that?
I mean, one of the things that we're seeing is that they're being treated a little more like a consumer device in that they have some disposability, right? So, I think one of the big things we didn't talk too much about, and we talked about a little bit, is the liability issue. And that's a huge issue, actually, in remote monitoring in terms of the physician side. Once you start getting this data, you have liability if you miss something. And the way it's provided to you now, lack of holistic or integrated form, you have issue. Well, in what you just talked about, now the device manufacturer has that same liability potentially if they create a device that doesn't perform as required in an environment where, as we know with most of our own consumer devices, we don't necessarily maintain them in the way that we should, right? So the manufacturers are taking much more of that consumer mentality. I got to assume it's going to be abused, I got to assume it's not going to be maintained, and I have to make it workable. One of the reasons why you're seeing more just simple devices, so things like Fitbit, things like scales, things that can do basic measurements, but it's not quote unquote life or death, and the calibration isn't quite as refined. Those are the ones that are more heavily used currently. But it does get very complex around that issue, and there's liability issues.
Either the rest of you have a comment to add?
No, I think for us, it's probably going to go into our sort of traditional biomedical engineering kind of thing. But we do already have devices out there, and people have a maintenance contract with Kaiser. We go up and service them, or they have vendors that do that as a third party. But I agree with Greg. I think it's pros and cons. I mean, if you have this device that could generate data, then and you prescribe it, you're liable for what you do with it. Whether you do anything with it, or whether you do the wrong thing, or you don't do it, or you ignore it. And one of the good things about having technology out there monitoring is that if you can use an algorithm to analyze it, an algorithm that the medical community accepts, it can defend, then you're actually protected. That is, you're actually more protected than if you just saw the person in clinic and you just happened to do blood pressure and you didn't catch the right blood pressure, whatever. When you have a systematic approach to things, that's quality. That's a kind of quality protection. Just like some of the research we've done in digital pathology, for instance. Digital pathology is data from looking at a slide of tissues. And there are companies that use automatic pattern matching to analyze the data, images. If you run the image through that and you analyze the entire slide, then you don't have a pathologist picking and choosing what they think were the susceptible areas. You actually have the protection of saying, we just analyze the whole thing. Just like when people they're wearing a blood pressure cuff 24 hours, like Fitbit or something, not blood pressure, but vital sign, you can say, well, if it didn't generate anything, we have at least an agreed upon protection in court, that we looked at the data, we analyzed it, and nothing came through. Whereas if you have that ability and you just did sporadic checks, so I think it's got some potential, depending on how you approach it, how you automate it. But a lot of these require the medical community to really get on board and agree on it. So.
Could I invite the three speakers to come up front, and then we'll open up to the audience. I see a hand in the back. Sir?
Among the many challenges, from an innovator's perspective, there's one that I really struggle with, and that's looking at that people are looking for solutions versus the need to scale, and particularly scaling systems that are very closed. We talked about support and deployability and integration was a challenge. So how do we create a solution that also needs to integrate with a very closed system, whether that's with Epic or with Qualcomm Life or something else?
That's a great question, because that's what Epic. You could argue Epic owns the market among the big IDNs and the big organizations that should be the big buyers of a lot of the remote monitoring solutions. And Epic is not an easy system to integrate with, but none of the EMRs are. So, it's...
You can see it from the vendor point of view. Right now with the HITECH Act, they're just in the business of selling until 2015 when the penalties come. So right now, everybody's buying medical records because the government is giving incentives and penalties later. So Epic, you can imagine if you sell a system to somebody and you make it easy to integrate with the system, get data out from it, to write data to it, the switching cost is much lower for the customer to switch to something else.
Yeah.
And that's always been an issue in healthcare. I mean, you can almost get as proprietary as you want to get to protect your position. But what's changing is that the government is really driving, opening up these systems for health information exchange, for demonstrating quality. You have to be able to analyze the data and so on and so forth. So I think I'm hopeful that that will help all the vendors get in the same field and go the right way.
Well, and there are solutions that are they are going to be sold, and once everybody's paid for all their EMRs, to build platforms on top. HP, IBM, Caradigm, the Microsoft, GE Healthcare joint venture are all looking at platform solutions that would go on top of all these clinical information systems and then allow that integration of all this data. So EMR would plug into that, but these other data streams would also plug in. So whether that takes off or not, we'll see.
So, got a question. Why don't people consider going to the HIE? Because the HIE talks to everybody instead of going to the EHR. Because there's 400 EHRs out there, and there's only like 6 or 8 HIEs that are viable today. So, do you know any reason why they wouldn't?
Well, HIEs have had a tough time.
Who's going to pay for HIE?
Yeah, that's the issue.
Well, a lot of people are paying for them.
But they don't have the integrated data stream either. All they're doing is transferring information, and generally they're transferring very minimal information. They're not transferring the depth of what's in an EMR.
I disagree with you because it's not from what I see, they're sending out whatever they can get. It comes in a continuity care record or a CCD or CDA, and that's one of the problems I've heard from doctors is they're getting too much. They're getting the whole, hidden from birth.
Part of it is because there's always been a debate about who owns what data. That's an issue. There's always been a debate on who owns data.
Yeah.
For instance, if you go to a system like Kaiser or Sutter or anybody else and have an EMR, a lot of that data was collected by the system, and they feel like they own it. Now, what is required by the government of the system to provide to the patient, they'll usually provide like a CCD or a CDA or something like that.
Which is a lot of data.
It's a lot of data, but it's only a summary. So it's not as rich as, as the EHR. And so it's a lowest common denominator. It's the least that they'll give you, that is. And it's interesting because I had a patient who was traveling to another country, and she asked me to get a summary, to bring a medical record on a flash drive. And we actually have the ability, guys, you can actually download a flash drive. But she could only get like a summary, and it's a very basic summary. And so she was kind of upset, I thought I would be able to take the whole thing, everything. And I said, don't feel bad, because I'm going to another country, and even I can't get it. I can only get the same that you got. And the reason is because our Epic system doesn't allow you to generate it.
But isn't that in violation of high-tech because you have to?
No, see, high-tech doesn't specify what you have to share. I mean, they don't really say that you can share this and this and this. So what systems share is they share a very abbreviated summary. And many times it's good enough. When a physician, let's say in the United States, sees a patient, they see the allergies, they see the operations, things like that. So it's usually good enough. And if they needed more, they'd probably call the physician.
How does that compare to before there was an electronic medical record? I know I could go into Kaiser and I could ask for a copy, or when I was coming to Kaiser and I needed to get my doctor, and they made photocopies of every page that was in that manila folder. They charged 25 cents a page or whatever, but the point was they seemed somehow obligated to give everything. And are you saying that now, in this new world, they're not obligated to give everything?
No. See, in the old days, really, if you ask the assistant in office to copy the record, you can't just say, oh, copy. You have to go through the copy page 2, no, don't copy page 3. Let's just copy the whole thing, it's just easier. But with the electronic record, you can specify the fields. In fact, the CDA defines certain fields. So it's a lot easier to send it like that and then still protect most of the data if you feel like you own it and you own it. A lot of these things, even healthcare systems, they don't want to share data because a lot of it's proprietary. Yeah, it's how they operate the business. They don't want to share that with a competitor, right? So, so there's a big issue there as well.
I think it's Scott.
You mentioned that the key thing is going to be the mobile phone or smartphone. It's going to be the key enabler, and then there's other systems coming on board for at-home type of monitoring. But the two social classes, the poor and the elderly, are without smartphones, right? I mean, I'm still trying to get my dad to get a cell phone. But
one, that's changing, right? I'm getting closer. I got one. But two, you can, if you have a solution that you want to send out, you can, you take a tablet price as they continue to fall, and you can put the tablet out in the field as part of your solution, right? So I think that's a short-term problem, not a long-term issue.
So absolutely. So right now you're talking about $7,500. 10 years we were talking about the people 65 years old are exposed to the high tech. So let's just address the 75 of our population, right? They don't have a smartphone, they don't know how to use touchscreen. Well, that's why I think there's two solutions out there, right? Number one is obviously I mentioned about the TuneNet solution. It does not require a patient to be aware of this. As long as they know how to stick the finger and put blood pressure on it, that's good enough. Second is, we talked about these home care, home health agencies, right? I think Dr. Chow mentioned. Actually, they're out there to helping to do that. Unfortunately, these are probably the two modalities they're going through. But in the end of the day, I think the key here is about passive and continuous. So I'll give you an example in terms of patient monitoring. Now, obviously, there's some privacy in regards to that. So let's say we have a sensor put in underneath your mattress, can measure how well you sleep. Imagine that I can put a sensor in your toilet. So if your mother, say your father, used to go to the bathroom 3 times in the night, and all of a sudden goes to 6 times. So that tells you something, right? So the thing is, you don't have to think about it, then these things becomes continuous and passive. Catch symptoms earlier.
Just I have a related question. It seems like smartphones and iPads are getting so much more acceptance with physicians and patients. Also, like that's the direction people want to go, and they want things to converge, and they want it on their really great interacting consumer devices. Where do you see the solution being to overcome the problem of unregulated operating systems now potentially conveying life-critical information?
Regulated by FDA?
Yeah, the fact, I mean, I work for a design firm, we work with big device corporations, and there's always this real reluctance to do anything on a phone, because what am I going to do when they issue another rev of the operating system, and suddenly I haven't qualified this, and I'm...
Well, it's interesting because, you know, we have at this point, over 20,000, quote, medical apps, but they're all consumer apps, and they're all fitness, and you can track your own blood pressure and weight, and encourage yourself, that kind of thing. And only a couple hundred real medical apps that tie in and send data to the medical provider. And that's the reason, because when you cross that line, the FDA becomes very interested because they see what you're positioning the device as. Now, physicians have always used devices off the record. I mean, they use this data. In fact, in Kaiser, for instance, you can enter your own data, your blood pressure that you've taken at home. The question is it a risk to your care? If the physician takes the blood pressure and uses it, then that device has to be certified by the FDA. And that's a lot of, and they try to, like I mentioned, they try to make it easier for these guys. But if you're actually measuring something and sending it and the physician's making a decision based on it, you're probably at least level 2 certification. So, yeah.
So the other
or
thing,
offload label.
Yeah, or doing it off.
One more question. One more question.
In the back. I wanted to know, does Kaiser or do other insurance companies, where do they draw the line of what they reimburse for in home monitoring? If they reimburse for the particular device, and then related to the other questions that have been asked recently, do they also reimburse for either the smartphone or the Windows PC or the Mac or whatever is the underlying platform that this device hooks to in order to get off to the cloud?
Well, I think that's sort of a future question, but Kaiser is self-insured, so we're kind of different than others. And so we saw a sense in doing it. We could actually do it. We're not constrained by who's paying for it and stuff. On the outside world, it's different because it's who wants to pay for it, and a lot of that is actually what is the standard of care. And that standard of care issue is huge. It's what keeps things slow in medicine, slow and conservative, and you can understand why. If you use a phone to report your blood pressure and the doctor's making heavy-duty decisions based on it, then that app is going to be flagged for the FDA, and they're going to have to make sure that it goes through certain quality things. And the interesting thing with FDA is that they have grandfathered the EHR, which is really interesting. But they're now starting to talk about the EHR, which is a huge change, because you can imagine the FDA regulating the medical record. That means you got to open it up. You got to have certain. I mean, think about medical record. The physician relies totally on it these days. It's critical. It has to be accurate. It has to be reliable. It has high quality data. Data has to be good integrity. All that kind of stuff. EMRs don't do today yet. But we have to do that. If they open up the system, then I think it's going to change the industry.
What is being reimbursed right now is cardiac care first 30 days after release, discharge. But beyond that, it really isn't, I don't think, there isn't much of anything. There's a couple areas where there are some post-discharge. What has to change is, you know, how we pay, right? So instead of paying for these as procedures, looking at, you know, we're starting to see, because CMS is now not going to reimburse for Medicare patients for 30 days after 3 different conditions, currently 2 cardiac and pneumonia as the third. Now we're starting to see solutions being able to be sold into hospitals. They're not reimbursed, but the hospital's willing to pay because they want to avoid the penalty that might come from CMS, right? So reimbursement is still very, very minimal for remote monitoring, and it's only tied to some really, you know, high-cost rehospitalization solution.
When do you see things changing?
I mean, everybody in the industry expects the change to be this movement towards ACOs, this movement towards being paid for outcomes, and therefore the need to have more preventative care. Now, one of the things that Jens pointing out is that Kaiser's sort of already in that model, in essence, right now, and yet they're measuring against what they currently do without all these technology gadgets and what the gadgets can do, and saying, well, it's not moving the needle enough in most cases. So, you know, what has to happen is that we have to be able to, I think, as we talked about, overcome some of these integration issues, some of the bigger picture issues that get at the larger changes in the market, not just the what can this little device do for in a data stream. So it's not an easy answer, and it's probably it's much more of a systematic issue than it is a technology issue in reality.
Okay, well, we are short on time. I have one last little thing about the healthcare IT SIG I'd like to ask you about. I'd like to ask any of you who are in the audience who have a topic that you'd like to present on or that you'd like to see covered. I'd like you to come up and give me your card, maybe scribble on the back of it, or just tell me how I can get in touch with you and share that information. We're looking to do our next meeting, as Paul said, in January, and we usually like to start planning pretty quickly after each meeting to work on the next one. If any of you would like to be involved in helping to find the speaker or volunteer in some way to help reach out and publicize the meetings, we appreciate hearing from you. So, you know, I'm going to stick around for a few minutes. We do have to straighten up the room. So, logistically, before we thank our speakers, I just want to ask you, please collect the things that you brought in. If you have had a sandwich or something, you can bring things over to the wastebasket. Help us to tidy up the room, because we're a guest in this room as an organization. We rent space in the building. So thank you for coming, and thank you to our speakers.